Hello class, welcome to Chapter 32, Environmental Emergencies. After students complete this chapter and the related coursework, they will understand the physiology of environmental emergencies. They will have learned the proper assessment and management of general and specific types of environmental emergencies, including hypothermia, local cold injuries such as frostbite, and heat exposure illnesses such as heat stroke. They will learn the associated signs and symptoms and emergency treatment of drowning, diving injuries, high altitude sickness, lightning strikes, and bites and envenomations from spiders, hypoporia, bees, yellow jackets, wasps, and ants, snakes, scorpions, ticks, and marine life. Introduction. Environmental factors such as temperature and atmospheric pressure can overwhelm a body's ability to cope with its surroundings. Medical emergencies can result. Certain populations are at higher risk: children, older people, people with chronic illness, young adults who overtax themselves. Environmental emergencies often accompany other illnesses and injuries that require treatment at the same time. Environmental emergencies include heat and cold-related emergencies, water emergencies, pressure-related injuries caused by diving and high-altitude climbing, injuries caused by lightning, envenomation caused by bites or stings. Factors affecting exposure. A number of factors affect how a person deals with heat or cold. Physical condition. Patients who are ill or in poor physical condition will not tolerate extreme temperatures well. Age. Children and older adults are more likely to experience temperature-related illnesses. Infants. Poor thermal regulation and an inability to shiver cannot generate heat when needed until about 12 to 18 months of age. Larger surface area and smaller mass. Children may not think to or be able to put on extra clothing. Older adults. Loss of subcutaneous tissue reduces insulation, poor circulation, and medications may affect thermal regulation. Nutrition and hydration. A lack of food or water will aggravate hot or cold stress. Calories provide fuel to burn, creating heat during the cold. Water provides sweat for evaporation and removing heat. Alcohol will change the body's ability to regulate temperature. Environmental conditions. Conditions that can complicate or improve environmental situations. Air temperature, humidity level, and wind. Extremes in temperature and humidity are not needed to produce hot or cold injuries. Most hypothermia occurs at temperatures between 30 degrees Fahrenheit and 50 degrees Fahrenheit. Most heat stroke occurs when the temperature is 80 degrees Fahrenheit and the humidity is 80%. Examine the environmental temperature of your patient. Older patients may not heat or cool their homes sufficiently. Cold exposure. If the body or any part of it is exposed to cold environments, temperature regulatory mechanisms may be overwhelmed. Cold exposure may cause injury to feet, hands, ears, nose, whole body, which is hypothermia. There are 5 ways the body can lose heat. Conduction, direct transfer of heat from a part of the body to a colder object by direct contact. Heat can also be gained if the substance being touched is warmed. Convection, transfer of heat into circulating air, as when cool air moves across the body. Heat can be gained if the air moving across the body is hotter than the temperature of the environment. Evaporation, conversion of any liquid to a gas. Natural mechanisms by which sweating cools the body. Radiation, transfer of heat by radiant energy, heat loss caused when a person stands in a cold room. Heat can also be gained by radiation. Respiration, loss of body heat during normal breathing. Warm air in the lungs is exhaled into the atmosphere, and colder air is inhaled. If the air temperature is above body temperature, an individual can gain heat with each breath. The rate and amount of heat loss or gained by the body can be modified in three ways: increase or decrease in heat production, shivering and increasing movement when cold, decreasing and limiting movement when hot. Move to an area where heat loss can be decreased or increased. Seek shelter from the wind in cold environments. Seek shade in hot environment to cool a patient down. Wear the appropriate clothing for the environment. Layers of clothing provide good insulation. Protective clothing traps perspiration and prevents evaporation. Loosen or remove clothing to cool down. Hypothermia. Core temperature of the body falls below 95 degrees Fahrenheit or 35 degrees Celsius. Temperature of the heart and lungs and vital organs. The body loses the ability to regulate its temperature and generate body heat. Physiology. To protect against heat loss, the body constricts blood vessels in the skin, resulting in blue lips or fingertips. The body shivers to generate heat. As these mechanisms are overwhelmed, body functions begin to slow down and mental status deteriorates. Eventually, key organs such as the heart begin to slow down. This can lead to death. Development of hypothermia can develop quickly, as with cold water immersion, can develop gradually, as with exposure to cold environment for several hours. Air temperature does not have to be below freezing for hypothermia to occur. People at risk. Homeless people or those whose homes lack heating. Swimmers, even in the summer. Geriatric, pediatric, and ill individuals who are less able to adjust the temperature to extremes. Patients with injuries or illnesses such as burns, shock, head injuries, stroke, generalized infection, injuries to the spinal cord, diabetes, hypoglycemia. Patients who have taken certain drugs or consumed alcohol. Signs and symptoms become more severe as the body's core temperature falls. Hypothermia generally progresses through 4 stages. No clear distinction between the stages. The different signs and symptoms will help to estimate the severity of the problem. Assess general temperature. Pull back your glove and place the back of your hand on the patient's abdomen. If the abdomen feels cool, the patient is likely experiencing a generalized cold emergency. You may carry a hypothermia thermometer, which registers lower body temperatures. Mild hypothermia occurs when the core temperature is between 90 degrees Fahrenheit and 95 degrees Fahrenheit. 32 degrees Celsius and 35 degrees Celsius. The patient is usually alert and shivering. Pulse rate and respirations are usually rapid. Skin may appear red, pale, or cyanotic. More severe hypothermia occurs when the core temperature is less than 90 degrees Fahrenheit, 32 degrees Celsius. Shivering stops, muscular activity decreases. Eventually, all muscular activity stops and mental status deteriorates. As the core temperature drops towards 85 degrees Fahrenheit or 29 degrees Celsius, the patient becomes lethargic and stops fighting the cold. The level of consciousness decreases. The patient may try to undress. Poor circulation, coordination, and memory loss follow along with reduced or complete loss of sensation to touch. Mood changes occur. The patient shows impaired judgment. The patient becomes less communicative. The patient experiences joint or muscle stiffness. The patient has trouble speaking, and the patient appears stiff or rigid. If the body temperature continues to fall to 80 degrees Fahrenheit or 27 degrees Celsius, vital signs show. Pulse becomes slower and weaker, respiration slow to shallow or become absent. Cardiac dysrhythmias may occur as the blood pressure decreases or disappears. At a core temperature of less than 80 degrees Fahrenheit, 27 degrees Celsius, all cardiorespiratory activity may cease. Pulmonary reaction is slow. Patient may appear dead or be in a coma. Never assume that a cold pulseless patient is dead. Local cold injuries. Most injuries from the cold are confined to exposed parts of the body. Extremities, especially the feet and hands, ears, nose, and face. When exposed parts of the body become very cold but not frozen, the condition is called frostnip, Caliban's, or immersion foot, trench foot. When the parts become frozen, the injury is called frostbite. The figure on this slide shows frostbite to the extremities and face. Important factors in determining the severity of a local cold injury: duration of exposure, temperature to which the body part was exposed, wind velocity during exposure. You should also investigate a number of underlying factors: exposure to wet conditions, inadequate insulation from cold or wind, restricted circulation from tight clothing or shoes, or circulatory disease, fatigue, poor nutrition. Alcohol or drug abuse, hypothermia, diabetes, cardiovascular disease, and age. Patients with hypothermia should also be addressed for frostbite or other local cold injury. Local and systematic cold exposure problems can occur in the same patient. Frostnip or immersion foot. Frostnip, after prolonged exposure to cold, skin may freeze while deeper tissues are unaffected. Usually affects the ears, nose, and fingers. Usually not painful, so the patient often is unaware that a cold injury has occurred. Immersion foot occurs after prolonged exposure to cold water. Common in hikers or hunters who stand for a long time in a river or a lake. Signs and symptoms. Skin is pale, blanched, and cold to the touch. Normal color does not return after palpation of the skin. The skin of the foot may be wrinkled, but can also remain soft. The patient reports loss of feeling and sensation in the injured area. Frostbite. Most serious local cold injury because the tissues are actually frozen. Freezing permanently damages cells. The exact mechanism by which the damage occurs is unknown. Gangrene. Permanent damage or cell death requires surgical removal of dead tissues. The exposed part will become inflamed, tender to the touch, and unable to tolerate exposure to cold. Signs and symptoms. Most frostbitten parts are hard and waxy. The injured part feels firm to frozen as you gently touch it. Blisters and swelling may be present. In light-skinned individuals with deep injury that has thawed or possibly thawed, the skin may appear red with purple and white, or it may be molted and cyanotic. The depth of skin damage will vary. With superficial frostbite, only the skin is frozen. With deep frostbite, deeper tissues are frozen. You may not be able to tell superficial from deep frostbite in the field. Assessment of cold injuries. Management of hypothermia in the field, regardless of the severity, consists of stabilizing the ABCs and preventing further heat loss. Scene size up. Scene safety. Note the environmental conditions, air temperature, wind chill, wet or dry. Ensure that the scene is safe for you and other research responders. Identify safety hazards such as icy roads, mud, or wet grass. Use appropriate standard precautions. Consider the number of patients you have. Summon additional help as quickly as possible. Mechanism of injury, nature of illness. Look for indicators of MOI. Primary assessment. Form a general impression. Perform a rapid scan to determine whether a life threat exists, and if so, treat it. If the chief complaint is simply being cold, quickly assess how cold the patient actually is. Check temperature by feeling the patient's skin on the abdomen. Evaluate the patient's mental status quickly using the AFPU scale. An altered mental status indicates the intensity of the cold injury. Airway, breathing, and circulation. If you believe the patient is in cardiac arrest, proceed directly to the circulation step by providing high-quality chest compressions, then address airway and breathing. Ensure that the patient has an adequate airway and is breathing. If the patient's breathing is slow or shallow, ventilation with a bag valve mask may be necessary. Warmed, humidified oxygen helps warm the patient from the inside out. Circulation. Palpate for a carotid pulse and wait up to 60 seconds to decide if the patient is pulseless. The American Heart Association recommends that CPR be started on a patient who has no detectable pulse or breathing. Perfusion will be compromised based on the degree of cold the patient is experiencing. The patient's skin will not be helpful in determining shock. Assume that shock is present and treat accordingly. Bleeding may be difficult to find because of slow-moving circulation and thick clothing. Transport decision. Complications can include cardiac dysrhythmias and blood clotting abnormalities. All patients with hypothermia require immediate transport. Assess the scene for the safest way to quickly move your patient from the cold environment. Rough handling of a hypothermia patient may cause a cold, slow, weak heart to fibrillate and the patient lose any pulse. If transportation is delayed, protect the patient from further heat loss. History taking. Investigate the chief complaint. Obtain a medical history. Be alert for injury-specific signs and symptoms, as well as any pertinent negatives. Sample history. If possible, find out how long your patient has been exposed to the cold environment. Exposures may be short or prolonged. Medications and underlying medical problems may have an impact on the way cold affects the patient's metabolism. The patient's last oral intake and what the patient was doing prior to exposure will help determine the severity of the cold problem. Secondary assessment. Physical examinations. Focus your physical examination on the severity of hypothermia. Assess the areas of the body directly affected by cold exposure. Address the degree and extent of damage. The numbing effect of cold both on the brain and on the body may impair your patient's ability to tell you about other injuries or illnesses. Vital signs. Vital signs may be altered by the effects of hypothermia and can be an indicator of its severity. Respirations may be slow and shallow, resulting in low oxygen levels in the body. Low blood pressure and slow pulse also indicate moderate to severe hypothermia. Evaluate your patient for changes in mental status using the AVPU scale. Monitoring devices. Determine a core body temperature using a hypothermia thermometer based on local protocol. Pulse oximetry will often be inaccurate due to the lack of perfusion in the extremities. Reassessment. Repeat the primary assessment. Reassess vital signs and the chief complaint. Monitor the patient's level of consciousness and vital signs. Rewarming can lead to cardiac dysrhythmias. Interventions. Review all treatments that have been performed. Reassess oxygen delivery. Remove any wet or frozen clothing. Do not remove any clothing that has frozen to the patient's skin. Communication and documentation. Communicate all of the information you have gathered to the receiving facility. Patient's physical status, condition at the scene, any changes in the patient's mental status during treatment and transport. General management of cold emergencies. Move the patient from the cold environment to prevent further heat loss. To prevent further damage to the feet, do not allow the patient to walk. Remove any wet clothing. Place dry blankets over and under the patient. If available, give the patient warm, humidified oxygen. Handle the patient gently. Do not massage the extremities. Do not allow the patient to eat or use any stimulants, i.e. coffee, tea, soda, or tobacco. Mild hypothermia. Patient is alert, shivering, and responds appropriately. Core body temperature is between 90 degrees Fahrenheit and 95 degrees Fahrenheit. Treatment involves passive rewarming. Place the patient in a warm environment. Remove wet clothing. Apply heat packs or hot water bottles to the groin, axillary, and cervical regions. Turn up the heat to high in the patient's compartment of the ambulance. To avoid burns, do not place heat packs directly on the skin. Give warm fluids by mouth if the patient can swallow. Moderate or severe hypothermia. Do not try to actively rewarm the patient. Rewarming may cause a fatal cardiac dysrhythmia. Local protocols may dictate the appropriate type of rewarming strategies based on the patient's body temperature. The goal is to prevent further heat loss. Remove the patient immediately from the cold environment. Place the patient in the ambulance. Remove wet clothing. Cover the patient with a blanket and transport. Handle the patient gently to decrease the risk of ventricular fibrillation. If you cannot get the patient out of the cold immediately, move the patient out of the wind and away from contact with any object that will conduct heat away from the body. Place blankets and waterproof protective cover over the patient. Cover the head and neck with a towel. Always remember that even an unresponsive patient may be able to hear you. Emergency care for local cold injuries. Emergency treatment of local cold injuries in the field should include the following steps. Remove the patient from further exposure to the cold. Handle the injured part gently and protect it from further injury. Remove any wet or restrictive clothing from the patient, especially over the injured part. If there is no chance of re-injury or if transport to the ED will be significantly delayed, consider active rewarming if local protocols allow. Consult medical control if available. With frostnip, contact with a warm object may be all that is needed. Your hands, your breath, the patient's own body. The affected part will often tingle and become red in light-skinned individuals. With immersion foot, remove wet shoes, boots, and socks. Rewarm the feet gradually, protecting it from further cold exposure. Splint the extremity and cover it loosely with dry, sterile dressing. Never rub or massage injured tissues. Rubbing can cause further damage. Do not re-expose the injury to cold. With a late or deep cold injury, frostbite, remove any jewelry from the injured part. Cover the injury loosely with dry, sterile dressing. Do not break blisters or rub or massage the area. Do not apply heat or rewarm the part. Do not allow the patient to stand or walk on a frostbitten foot. Splinting of the frostbitten extremity may help prevent secondary injury. Evaluate for signs and symptoms of systematic hypothermia. Transport the patient promptly to the hospital. Rewarming in the field. If prompt hospital care is not available and medical control instructs you to begin rewarming in the field, use a warm water bath. Immersion of the frostbitten part in water with a temperature between 102 degrees Fahrenheit and 104 degrees Fahrenheit. Check the water temperature with the thermometer before immersing the limb. Recheck the temperature frequently during the rewarming process. The water temperature should never exceed 105 degrees Fahrenheit. Stir the water continuously. Keep the frostbitten part in the water until it feels warm and sensation has returned. Dress the area with dry, sterile dressings, including between injured fingers or toes. Expect the patient to report severe pain. Never attempt rewarming if there is any chance that the part may freeze again before the patient reaches the hospital. Cover the frostbitten part with soft, padded, sterile cotton dressings. If blisters have formed, do not break them. Cold exposure in you. You are at risk for hypothermia yourself if you work in a cold environment. If cold weather search and rescue is possible in your area, then you need survival training and precautionary tips. Stay on top of weather forecasts, make sure proper clothing is available, and wear it whenever appropriate. Your vehicle must also be properly equipped and maintained. You cannot help others if you do not protect yourself. Heat exposure. In a hot environment or during vigorous physical activity, the body tries to rid itself of excess heat. Sweating and evaporation of the sweat. Dilation of skin blood vessels. Removal of clothing and relocation to a colder environment. Hyperthermia is a core temperature of 101 degrees Fahrenheit or higher. When heat gained exceeds heat loss, hyperthermia results. Risk factors for heat illness. High air temperature reduces radiation. High humidity reduces evaporation. Lack of accumulation to the heat. Vigorous exercise, loss of fluid and electrolytes. A heat emergency can take the following three forms: heat cramps, heat exhaustion, or heat stroke. All three forms may be present in the same patient. Persons at great risk for heat illnesses are children, especially newborns and infants, geriatric patients, patients with heart disease, COPD, diabetes, dehydration, and obesity, patients with limited mobility. Alcohol and certain drugs also make a person more susceptible to heat illnesses. Heat cramps. Painful muscle spasms that occur after vigorous exercise do not occur only when it is hot outdoors. Exact cause is not well understood. Dehydration may play a role in the development of muscle cramps, usually occur in the leg or abdominal muscles. Heat exhaustion, also called heat prostrain or heat collapse. Most common heat emergency. Causes: heat exposure, stress, fatigue, hypovolemia as a result of loss of water and electrolytes from heavy sweating. People who work or exercise vigorously and those who wear heavy clothing in warm, humid, or poorly ventilated environments are particularly prone to heat exhaustion. Signs and symptoms: dizziness, weakness, or syncope, muscle cramping, onset while working hard or exercising in hot, humid, or poorly ventilated environment, and sweating heavily. Onset: even at rest in older or infant age groups in hot, humid, and poorly ventilated environments, or extended time in hot, humid environments. Cold, clammy skin with ashen pallor, dry tongue and thirst. Normal vital signs, although the pulse is often rapid and weak, and the diastolic blood pressure may be low. Normal or slightly elevated body temperature on rare occasions as high as 104 degrees Fahrenheit. Heat stroke. Least common but more serious injury caused by heat exposure. Occurs when the body is subjected to more heat than it can handle and normal mechanisms of getting rid of the excess heat are overwhelmed. Untreated heat stroke always results in death. Typical onset situations. During vigorous physical activity, outdoors or in a closed, poorly ventilated, humid space. During heat waves in a building without sufficient air conditioning or with poor ventilation. Children left unattended in a locked car on a hot day. Signs and symptoms. Hot, dry, flushed skin. Skin may be moist or wet due to exertion by the patient. Quickly rising body temperature, 106 degrees Fahrenheit or higher. Falling level of consciousness, leading to unconsciousness. Change in behavior and unresponsiveness. Seizures, strong, rapid pulse at first, becoming weaker and falling blood pressure, increasing respiratory rate, lack of perspiration, body has lost its thermoregulatory mechanisms. Assessment of heat injuries. Scene size up. Scene safety. Perform an environmental assessment. Remember that the heat emergency may be secondary to the mechanism or trauma emergency. If the patient is unconscious, has an altered mental status, or requires intravenous fluids to treat shock, consider calling for ALS assistance. Look for indicators of the MOI. If the patient is immersed in cold water immersion bath upon your arrival, monitor the patient in the water and assist as necessary. Do not remove the patient until the temperature has normalized to an appropriate level between 101 degrees Fahrenheit and 102 degrees Fahrenheit. Do not overcool the patient. Protect yourself from heat and stay hydrated. Use appropriate standard precautions, including gloves and eye protection. Primary assessment. Form a general impression. Observe the patient, how the patient interacts with you in the environment. Introduce yourself and ask about the chief complaint. A heat emergency may be the primary or secondary condition. Perform a rapid scan and avoid tunnel vision. Assess the patient's mental status using the AFPU scale. The more altered the patient's mental status, the more serious the heat problem. Airway and breathing. Unless the patient is unresponsive, the airway should be patent. Nausea and vomiting may occur. Position the patient to protect the airway as necessary. If the patient is unresponsive, be cautious of how you open the airway and consider spinal mobilization if trauma is a possibility. If the patient is unresponsive, insert an airway and provide bag valve mask ventilations. Circulation, if adequate access for perfusion and bleeding. Assess the patient's skin condition. Treat for shock by removing the patient from the heat and positioning the patient to improve circulation. If the patient is bleeding, bandage according to protocol. If the patient has any signs of heat stroke, provide rapid transport. History taking. Investigate the chief complaint. Be alert for specific signs and symptoms, absence of perspiration, decreased level of consciousness, confusion, muscle cramping, nausea, vomiting. Sample history. Note any activities, conditions, or medications that may predispose a patient to dehydration or heat-related problems. Inadequate oral intake, diuretics, many medications used by geriatric patients. Determine your patient's exposure to heat and humidity and activities prior to onset of symptoms. Secondary assessment. Physical examination. If the patient is unresponsive, perform a secondary assessment on the entire body. If the patient is conscious, perform an assessment of the specific areas of the body. Assess the patient for muscular cramps or confusion. Examine the patient's mental status and take vital signs. Pay special attention to the patient's skin temperature, temperature, and level of moisture. Gently pinch the skin of the forehead or back of the hand. Normally the skin will quickly flatten out. In dehydration, with poor skin temperature, the skin will remain tinted. Perform a careful neurologic examination. Vital signs. Patients who are hyperthermic will be tachycardic and tachypneic. Falling blood pressure indicates that the patient is going into shock. In heat exhaustion, the skin temperature may be normal or cool and clammy. In heat stroke, the skin is hot. Monitoring devices. Check the patient's temperature with a thermometer, depending on protocol. In patients with heat-related emergency, pulse oximetry is also indicated. Reassessment. Watch carefully for deterioration, especially decline in level of consciousness. Patients with symptoms of heat stroke should be transported immediately. Transport in a cool ambulance. Passively cool with clothing removed. Actively cool by spraying the patient with water and fanning to enhance evaporation. Monitor vital signs at least every 5 minutes. Evaluate the effectiveness of your interventions. Be careful not to overcool the patient. Communication and documentation. Inform the staff of the receiving facility early on that your patient is experiencing heat stroke, because additional resources may be required. Document environmental conditions and the activities the patient was performing prior to onset. Management of heat emergencies. Heat cramps. Take the following steps to treat heat cramps in the field. Remove the patient from the hot environment and loosen any tight clothing. Administer high flow oxygen if indicated. Resting the cramping muscles. Have the patient sit or lie down until the cramps subside. Replace fluids by mouth. Use water or diluted balanced electrolyte solution. Do not give salt tablets or solutions that have a high salt concentration. Cool the patient with water spray or mist and add convection by manually or mechanically fanning the patient. When the heat cramps are gone, the patient may resume activity. The best preventive and treatment strategy is hydration by drinking water. If the cramps do not go away after these measures, transport the patient to the hospital. Heat exhaustion. To treat the patient with heat exhaustion, follow the steps in Skill Drill 32-1. Heat stroke. Recovering from heat stroke depends on the speed with which treatment is administered. You may be able to identify the patient quickly. Emergency treatment has one objective: lower the body temperature by any means available. Take the following steps when treating patients with heat stroke. Move the patient out of the hot environment and into the ambulance. Set the air conditioning to maximum cooling. Remove the patient's clothing. Administer high-flow oxygen if indicated. If needed, assist ventilations with a bag valve mask and appropriate airway adjuncts per local protocol. Provide cold water immersion if possible. Cover the patient with wet towels or sheets, or spray the patient with cool water and fan him or her to quickly evaporate the moisture on the skin. Aggressively and repeatedly fan the patient. Exclude other causes of altered mental status. Check blood glucose level if possible. Transport immediately to the hospital. Notify the hospital of an arriving heat stroke patient. Do not overcool the patient. Call for ALS assistance if the patient begins to shiver. Drowning. Drowning is the process of experiencing respiratory impairment from submersion or immersion in a liquid. Some agencies may still use the term near drowning to refer to a patient who survives, at least temporarily, 24 hours after suffocation in water. Risk factors: alcohol consumption, pre-existing seizure disorders, geriatric patients with cardiovascular disease, unsupervised access to water for children. Drowning is often the last in a cycle of events caused by panic in the water. It can happen to anyone who is submerged in water for even a short period of time. Struggling towards the surface or shore, the person becomes fatigued or exhausted, which leads to him or her to sink even deeper. Drowning also occurs in buckets, puddles, and bathtubs, etc. Young children can drown in as little as an inch of water. Laryngeal spasm. Inhaling very small amounts of either fresh water or salt water can severely irritate the larynx. The muscles of the larynx and vocal cord spasm. Prevents more water from entering the lungs. In cases, progressive hypoxia occurs while the patient becomes unconscious. The spasm relaxes. The patient may now inhale deeply. More water may enter the lungs. Spinal injuries and submersion incidents. Submersion incidents may be complicated by spinal factors and spinal cord injuries. Assume that the spinal injury exists if the following conditions: the submersion has resulted from a diving mishap or a significant fall. The patient is unconscious and no information is available to rule out the possibility of a neck injury. The patient is conscious but complains of weakness, paralysis, or numbness in arms or legs. You suspect the possibility of spinal injury despite what witnesses say. Most spinal injuries in diving incidents affect the cervical spine. Stabilize the suspected injury while the patient is still in the water. Follow the steps in Skill Drill 32-2. Safety. Ensure the safety of the rescue personnel and request additional resources for a water rescue. Water rescues are usually handled by specialized rescue personnel. The basic rule of water rescue is reach, throw, and row, and only then go. Reach for the person from the shore or wade into the water. If an object that floats is available, throw it to the person. Use a boat if available. If you must swim to the person, use a towel or board for him or her to hold on to. Do not attempt a swimming rescue unless you are trained and experienced in proper techniques. If you work in an area near lakes, rivers, or the ocean, you should have prearranged plan for water rescues. Recovery techniques. If the patient is not floating or visible in the water, an organized rescue effort is necessary. Specialized personnel are required with snorkel, mask, and scuba gear. Scuba, self-contained underwater breathing apparatus. Gear is a system that delivers air to the mouth and lungs at atmospheric pressures that increase with the depth of the dive. Resuscitation efforts. Never give up on resuscitating a cold water drowning victim. Hypothermia can protect vital organs from lack of oxygen. Exposure to cold water will occasionally activate certain primitive reflexes which may prevent basic body functions for prolonged periods. The diving reflex, slowing of the heart rate caused by submersion in cold water, may cause immediate bradycardia, slow heart rhythm. A person may be able to survive for an extended period of time underwater thanks to the lowering of the metabolic rate associated with hypothermia. Local protocols often dictate that resuscitative efforts continue for up to 1 hour after submersion while simultaneously rewarming the patient. Diving emergencies. Most serious water-related emergencies are associated with dives with or without scuba gear. Some of those problems are related to the nature of the dive, others result from panic. Panic can happen even to an experienced diver or swimmer. Medical emergencies relating to scuba diving techniques and equipment are becoming increasingly common. Separated into 3 phases: descent, bottom, and ascent. Descent emergencies, caused by the sudden increase in pressure on the body as the person dives deeper into the water. Typical areas affected: lungs, sinus cavities, middle ear, teeth, area of the face surrounded by the diving mask. Usually the pain caused by these squeeze problems forces the diver to return to the surface to equalize the pressure, and the problem clears up by itself. Divers with continued pain, particularly in the ear after returning to the surface, should be transported to the hospital. Perforated tympanic membrane or ruptured eardrum. Cold water may enter the middle ear through the ruptured eardrum. The diver may lose his or her balance and orientation. The diver may shoot to the surface and run into ascent problems. Emergencies at the bottom rarely occur, caused by faulty connections to diving gear, inadequate mixing of oxygen and carbon dioxide in the air the diver breathes, accidental feeding of poisonous carbon monoxide into the breathing apparatus, can cause drowning or rapid ascent, require emergency resuscitation and transport. Ascent emergencies. Most serious injuries and usually require aggressive resuscitation. Air embolism. Most dangerous and most common scuba diving emergency. Bubbles in the air in the blood vessels. The problem starts when the diver holds his or her breath during rapid ascent. The air pressure in the lungs remains at a high level while external pressure on the chest decreases. The air inside the lungs expands rapidly, causing the alveoli in the lungs to rupture. Complications. Air may enter the pleural space and compress the lungs, pneumothorax. Air may enter the mediastinum, the space within the thorax that contains the heart and great vessels, causing a condition known as a pneumomelastatum. Air may enter the bloodstream and create bubbles of air in the vessels called air emboli. Signs and symptoms of air embolism: blotching, molting of skin, froth, often pink or bloody from the nose or mouth, severe pain in muscles, joints, or abdomen, dyspnea and or chest pain, dizziness, nausea, and vomiting, dysphoria, difficulty speaking, cough, cyanosis, difficulty with vision, paralysis and or coma, irregular pulse, and even cardiac arrest. Decompression sickness. The bends. Bubbles of gas, especially nitrogen, obstruct the blood vessels. Conditions that can cause the decompression sickness: too rapid an ascent from a dive, too long a dive at too deep a depth, repeated dives within a short period of time, driving a car up a mountain, or flying in an unpressurized airplane that climbs too rapidly soon after a dive. Nitrogen that is being breathed dissolves in the blood and tissues. The diver ascends and the external pressure is decreased. Dissolving the nitrogen forms small bubbles within these tissues. Complications: blockage of tiny blood vessels, depriving parts of the body of their normal blood supply. Severe pain in certain tissues or spaces. Signs and symptoms: abnormal joint pain so severe that the patient doubles up, bends. You may find it difficult to distinguish between an air embolism and decompression sickness. Air embolism generally occurs immediately on the return to the surface. Symptoms of decompression sickness may not occur for several hours. Emergency treatment is the same for both. Basic life support, BLS, recompression in a hyperbaric chamber. Assessment of drowning and diving emergencies. Scene size up. Scene safety. Your standard precautions should include gloves and eye protection at a minimum. Never drive through moving water. Be cautious when driving through still water. Never attempt a water rescue without proper training and equipment. Call for additional resources early. Trauma and spinal immobilization must be considered in recreational settings. Check for additional patients depending upon the situation. Mechanism of injury, nature of illness. Look for the indicators of the MOI. Consider how the MOI produced the injuries expected. Primary assessment. Form a general impression. Pay attention to the chest pain, dyspnea, or complaints of sensory changes when a diving emergency is suspected. Determine the patient's level of consciousness using the AFPU scale. Be suspicious of drug or alcohol use. Airway and breathing. Open the airway and assess breathing in unresponsive patients. Consider the possibility of spinal trauma and take appropriate actions. The airway may be obstructed with water. Suction if the patient has vomited. Provide ventilations with a bag valve mask for inadequate breathing. Use an airway adjunct as necessary. If the patient is responsive, provide high flow oxygen with a non-rebreather mask. Auscultation and frequent reassessment of breath sounds in drowning patients is a key part of your assessment. Circulation. It may be difficult to find a pulse. If the pulse is unmeasurable, the patient may be in cardiac arrest. Begin CPR and apply your AED. Evaluate for shock and adequate perfusion. If the MOI suggests trauma, assess for bleeding and treat appropriately. Transport decision. Always transport patients to the hospital. Inhalation of any amount of fluid can lead to delay complications lasting for days or weeks. Decompression sickness and air embolism must be treated in a recompression chamber. Perform all interventions en route. History taking. Investigate the chief complaint. Obtain a medical history. Be alert for injury-specific signs and symptoms as well as any pertinent negatives. Sample history. Determine the depth of the dive, the length of time the patient was underwater, the time of onset of symptoms, and previous diving activity. Note any physical activity, alcohol or drug use, or any other medical conditions. Secondary assessment. Physical examinations. If the patient is unresponsive, thoroughly examine his or her lungs, including breath sounds. If unresponsive, look for hidden life threats and potential trauma, even if trauma is not suspected. For scuba divers, look for indications of decompression sickness or air embolism. Check for signs of hypothermia. Complete a detailed assessment en route to the hospital. Assess for peripheral pulses, skin color and discoloration, itching, pain, paracentesis, numbness, or tingling. Vital signs. Check the patient's pulse rate, quality, and rhythm. May be difficult to palpate in a hypothermic patient. Check for both peripheral and central pulses. Listen over the chest for a heartbeat if pulses are weak. Check the respiratory rate, quality, and rhythm, and listen for lung sounds. Assess and document pupil size and reactivity. Monitoring devices. Oxygen saturation readings may produce a false low reading because of hypoperfusion or shivering. Reassessment. Repeat the primary assessment. Drowning patients may deteriorate rapidly due to pulmonary injury, fluid shifts in the body, cerebral hypoxia, hypothermia. Patients with pneumothorax, air embolism, or decompression sickness may decompensate quickly. Assess your patient's mental status constantly. Assess vital signs at least every 5 minutes, paying particular attention to respirations and breath sounds. Communication and documentation. Document the circumstances of the drowning and extraction. How the patient was submerged, temperature of the water, clarity of the water, possible spinal injury. Bring a dive log or dive computer if available to record the dive history. Bring all dive equipment to the hospital and document the disposition of those materials. Emergency care for drowning or diving emergencies. Treatment of drowning begins with the rescue and removal from the water. Immobilize and protect the patient's spine when a fall from a significant height or suspected diving injury is possible. Artificial ventilation should begin as soon as possible, even before the victim is removed from the water. If the patient is not breathing, remove any vomit from the airway manually or by suction. Assist ventilations with a bag valve mask or pocket mask. Rolling patient onto their side or performing abdominal thrusts will not remove water from the lungs and should not be done unless the airway is obstructed. Address airway and breathing concerns first. Then begin compressions and use the AED. Administer oxygen if the patient is breathing spontaneously. Use pulse oximetry to titrate oxygen delivery according to local protocols. Treat for hypothermia. When treating conscious patients who are suspected of having an air embolism or decompression sickness from scuba diving, follow these treatment steps. Remove the patient from the water and try to keep him or her calm. Administer oxygen. Consider the possibility of pneumothorax and monitor breath sounds. Provide prompt transport to the ED or nearest recompression facility for treatment based on local protocols. Other water hazards. Pay close attention to body temperature of the patient who is rescued from cold water. Treat hypothermia caused by immersion in cold water the same way you treat hypothermia caused by cold exposure. Breath-holding syncope. A person swimming in shallow water may experience a loss of consciousness caused by a decreased stimulus for breathing. Happens to swimmers who breathe in and out rapidly and deeply before entering the water, in effect to expand their capacity to stay underwater. Hyperventilation lowers the carbon dioxide level. The swimmers may not feel the need to breathe even after using up all the oxygen in his or her lungs. Treatment is the same for that of a drowning patient. Prevention. Appropriate precautions can prevent most emergent incidents. All pools should be surrounded by a fence. The most common problem in child drownings is the lack of adult supervision. Half of all teenage and adult drownings are associated with the use of alcohol. High altitude. Disbarum injuries, caused by the difference between the surrounding atmospheric pressure and the total gas pressure in various tissues, fluids, and cavities in the body. Altitude illness occur when an unacclimatized person is exposed to diminished oxygen pressure in the air at high altitudes. Illness can affect the central nervous system and pulmonary system. Acute motion sickness above 5,000 feet. Diminished oxygen in the blood, hypoxia caused by ascending too high, too fast, or not being acclimatized to high altitudes. Signs and symptoms: headache, lightheadedness, fatigue, loss of appetite, nausea, difficulty sleeping, shortness of breath during physical exertion, swollen face. Treatment primarily consists of stopping the ascent and descending to lower altitude. High altitude pulmonary edema, above 8,000 feet. Fluid collects in the lungs, hindering the passage of oxygen into the bloodstream. Signs and symptoms: shortness of breath, cough with pink sputum, cyanosis, and rapid pulse. High altitude cerebral edema, above 12,000 feet. May accompany HAPE and can quickly become life-threatening. Symptoms of HACE and HAPE may overlap. Severe constant throbbing headache, ataxia, lack of muscle coordination and balance, extreme fatigue, vomiting, and loss of consciousness. Treatment of HAPE and or HACE. Provide oxygen, descend from the height, transport promptly. Provide positive pressure ventilation with a bag valve mask for inadequate respirations. CPAP may be helpful if allowed by local protocols. Lightning. There are an estimated 25 billion cloud-to-ground lightning strikes each year in the United States. Lightning is the third most common cause of death from isolated environmental phenomena. Targets of direct lightning strikes: people engaged in outdoor activities, boaters, swimmers, golfers, anyone in a large open area. Many individuals are indirectly struck when standing near an object that has been struck by lightning, such as a tree. This is called the splash effect. The cardiovascular and nervous system are most commonly injured. Respiratory and cardiac arrest is most common cause of lightning-related deaths. The tissue damage pathway usually occurs over the skin rather than through it. Look for not only the entrance wound, but also the exit wound. Because the duration of lightning strike is short, skin burns are usually superficial. Categories of lightning injuries: mild, loss of consciousness, amnesia, confusion, tingling, other non-specific signs and symptoms. Burns, if present, are typically superficial. Moderate, severe seizures, respiratory arrest, dysrhythmias that are spontaneously resolved, superficial burns. Severe, cardiopulmonary arrests. Many of these patients do not survive. Emergency medical care. Take measures to protect yourself from being struck by lightning. Move the patient to a sheltered area. If shelter is not available, recognize the signs of an impending lightning strike and take immediate action to protect yourself. If you suddenly feel a tingling sensation or your hand stands on end and the area around you becomes charged, sign of an imminent lightning strike. Make yourself as small a target as possible by squatting down into a ball close to but not touching the ground. Move away from trees or other tall objects. Use reverse triage. Anyone who is in cardiac or respiratory arrest is the first priority. Other people who may have been struck will not develop cardiac complications. Treatment: stabilize the spine and open the airway with the jaw thrust maneuver. If pulse is present, assist with ventilations. If the patient is in cardiac arrest, use an AED as soon as possible. If severe bleeding is present, control it immediately. Transport to the nearest facility. A patient with signs and symptoms of a lightning strike, but no obvious life threats, should still be transported for evaluation. Bites and envenomations. Spider bites. Spiders are numerous and widespread in the United States. Most species of spiders bite. Only two spiders, the female black widow spider and the brown recluse spider, deliver serious, even life-threatening bites. Be alert to the possibility that a spider may still be in the area. Your safety is of paramount importance. Black widow spider. The female black widow spider is fairly large, measuring approximately 2 inches with its legs extended. Usually black with a distinctive bright red-orange marking in the shape of an hourglass on its abdomen. The female is larger and more toxic than the male. Found in every state except Alaska. prefer dry, dim places around buildings and wood piles and among debris. The bite is sometimes overlooked. If the site becomes numb right away, the patient might not even recall being bit. However, most black widow spider bites cause localized pain and symptoms including agonizing muscle spasms. A bite on the abdomen may cause muscle spasms so severe that they resemble an acute abdominal condition. The main danger is the venom, which can damage nerve tissues. Other systematic symptoms: dizziness, sweating, nausea, vomiting, rashes, tightness in the chest, difficulty breathing, and severe cramps. Generally, these signs and symptoms subside over 48 hours. A physician can administer a specific antivenom, but because of high incidence and side effects, it is reserved for very severe bites, the aged or very feeble, children under 5 years. Emergency treatment consists of BLS for the patient in respiratory distress. Transport to emergency department as soon as possible. If possible, safely bring the spider to the hospital or take a picture of the spider with a cell phone and send it to the hospital ahead of time. Brown recluse spider. Dull brown in color and about an inch long. The short-haired body has a violin-shaped mark, brown to yellow in color, on its back. Lives mostly in southern and central parts of the country, but may be found throughout the continental United States. Tends to live in dark areas such as in corners of old unused buildings, under rocks, and in wood piles. In cooler areas, it moves indoors to closets, drawers, cellars, and clothing. The venom is not neurotoxic but cytotoxic. It causes severe local tissue damage. Typically, the bite is not painful at first, but becomes so within hours. The area becomes swollen and tender, developing a pale molted cyanotic center and possibly a small blister. A scab of dead skin, fat, and debris will form and dig down into the skin, producing a large ulcer that may not heal unless treated promptly. Transport patients with such symptoms as soon as possible. These bites rarely cause systematic symptoms and signs. When they do, the initial treatment is BLS and transportation to the emergency department. If possible, safely bring the spider or take a photo of the spider with the cell phone and send it to the hospital ahead of time. Hemoptera stings. Bees, wasps, yellow jackets, and ants. Stings are painful but are not a medical emergency. Remove the stinger and venom sac using a firm-edged item such as a credit card to scrape the stinger and sac off the skin. Use ice packs to assist in controlling pain for a Hemoptera sting. Anaphylaxis may occur if the patient is allergic to the venom. Signs and symptoms: flushed skin, low blood pressure, difficulty breathing, usually associated with reactive airway sounds, swelling to the throat and tongue. Dire emergency can be fatal. Hives near the site of envenomation or centrally on the body. Be prepared to assist the patient in administering an EpiPen autoinjector and support the airway and breathing. Snake bites. Snake bites are a worldwide problem. Snake bite fatalities in the United States are extremely rare, about 15 a year for the entire country. Of the approximately 115 different species of snakes native to the United States, only 19 are venomous. These include the rattlesnake, the copperhead, the coppermouth or water moccasin, and coral snakes. At least one of these poisonous species is found in every state except Alaska, Hawaii, and Maine. The figure on this slide shows species of poisonous snakes that are found in the United States. Rattlesnake is picture A, copperhead is picture B, cottonmouth or water snake is picture C, and the coral snake is picture D. Snakes usually do not bite unless provoked, angered, or accidentally injured, as when they are stepped on, except for cottonmouths, which are often aggressive. Most snake bites occur between April and October and tend to involve young men who have been drinking. Protect yourself from getting bitten, use extreme caution on those calls, and wear the proper protective equipment for the area. Only 1/3 of snake bites result in significant local or systematic injuries. Often, envenomation does not occur because the snake recently struck another animal or exhausted its supply of venom. Venomous snakes native to the United States have hollow fangs in the roof of their mouth that inject the poison from 2 sacs at the back of the head. The classic appearance of a poisonous snake bite is 2 small puncture wounds, usually about ½ an inch apart, with discoloration, swelling, and pain. Non-poisonous snakes can also bite, usually leaving a horseshoe of teeth marks. Fang marks are a clear indication of a poisonous snake bite. Pit vipers. Rattlesnakes, copperheads, and coppermouths are all pit vipers with triangular-shaped flat heads. They have small pits that contain poison located just behind each nostril in front of each eye. The pit is a heat-sensing organ that allows the snake to strike accurately at any warm target. The fangs are special hollow teeth that act like hypodermic needles connected to a sac containing a reservoir of venom. Rattlesnakes. Most common form of pit viper have many patterns of color, often with a diamond pattern. Can grow up to 6 feet or more in length. Copperheads. Smaller than rattlesnakes, usually 2 to 3 feet long. Red copper color crossed with brown or red bands. Typically inhabitant of wood piles or abandoned dwellings. Account for most of the venomous snake bites in the eastern United States. Their bites are almost never fatal, but the venom can cause significant damage to tissues and extremities. Cottonmouths. Grow up to about 4 feet in length, also called water moccasins. Olive or brown with black cross bands and yellow undersurface. They are water snakes with an aggressive pattern of behavior. Although fatalities from these snake bites are rare, tissue destruction from the venom may be severe. The signs of envenomation by a pit viper are severe burning pain at the site of injury, followed by swelling and a bluish discoloration. Signs are evident within 5 to 10 minutes and spread over the next 36 hours. In addition to destroying tissues locally, the venom of a pit viper can also interfere with the body's clotting mechanism and cause bleeding at various distant sites. Other signs may or may not include weakness, nausea, vomiting, sweating, seizures, or fainting. Vision problems, changes in the level of consciousness, and shock. If the patient has no local signs an hour after being bitten, it is safe to assume that the envenomation did not take place. When treating a bite from a pit viper, take the following steps. Calm the patient. Place the patient in a supine position and explain that staying quiet will slow the spread of any venom through the system. Locate the bite area and clean it gently with soap and water. Do not apply ice. If the bite occurred on an arm or leg, consider using a pressure immobilization bandage for the extremity. Then place the affected extremity below the level of the heart. Be alert for an anaphylactic reaction to the venom and treat with an epinephrine autoinjector as appropriate. Do not give anything by mouth and be alert for vomiting. If the patient was bitten on the trunk, keep him or her supine and quiet and transport as quickly as possible. Monitor vital signs and mark the skin with a pen over the area that is swollen to note whether the swelling is spreading. If there are any signs of shock, treat for it. If the snake has been killed, bring it with you. Alternatively, take a picture of the snake with a cell phone and send it to the hospital ahead of time. Notify the hospital that the patient has been bitten by a snake. If possible, describe the snake. Transport promptly. If the patient shows no signs of envenomation, provide BLS as necessary, place a sterile dressing over the suspected bite area, and immobilize the injury site. All patients with suspected snake bite should be taken to the emergency department. Treat the wound as you would any deep puncture wound to prevent infection. Familiar yourself with the venomous snakes in your region as well as any local protocols for handling snake bites. Coral snakes. Small reptile with a series of bright yellow and black bands completely encircling the body. Red on yellow will kill a fellow. Red on black, venom will lack. A relative of the coral snake, it lives in most southern states of the Southwest. It injects the venom with its teeth and tiny fangs by chewing motion, leaving puncture or scratch-like wounds. Because of its small mouth and teeth and limited jaw expansion, the coral snake usually bites its victims on small parts of the body such as a finger or toe. Coral snake venom is a powerful toxin that causes paralysis of the nervous system. Within a few hours of being bitten, a patient will exhibit bizarre behavior followed by progressive paralysis of eye movements and respiration. Successful treatment depends on positive identification of the snake and supportive respirations. Antivenom is available, but most hospitals do not stock it. Emergency care of coral snake bite are the same as a pit viper bite. Scorpion stings. Scorpions are 8-legged arachnids with venom gland and a stinger at the end of its tail. They are rare and live primarily in the southwestern United States and in deserts. With one exception, a scorpion sting is usually very painful but not dangerous, causing localized swelling and discoloration. The figure on this slide shows a scorpion. The exception is the Centropus scrupulus. The venom of this species may produce a severe systematic reaction that brings about circulatory collapse, severe muscle contractions, excessive salivation, hypertension, convulsions, and cardiac failure. If you are called to care for a patient with suspected sting from C. scrupulus, notify medical control as soon as possible. Administer BLS and transport the patient as rapidly as possible. Tick bites. Ticks are tiny insects that usually attach themselves directly to the skin. They are found most often on bush, shrubs, trees, sand dunes, and other animals. Only a fraction of an inch in length, they can easily be mistaken for freckles. The bite is not painful. The danger with a tick bite is from the infectious diseases spread through the tick's saliva. The figure on this screen shows a tick and the characteristic bullseye pattern rash associated with Lyme disease. Rocky Mountain spotted fever occurs within 7 to 10 days after the bite. Symptoms: nausea, vomiting, headache, weakness, paralysis, and cardiorespiratory collapse. Lyme disease, reported in all states with the exception of Hawaii, occurs most commonly in the Northeast and the Great Lakes states. The first symptoms are generally fever and flu-like symptoms, sometimes associated with a bullseye rash that may spread to several parts of the body. After a few more days or weeks, painful swelling of joints, particularly the knees, occur. Lyme disease may be confused with rheumatoid arthritis and may result in permanent disability. If it is recognized and treated promptly with antibiotics, the patient may recover completely. Tick bites occur most commonly during the summer months. In conventional EMS settings with tick bite or signs and symptoms of Lyme disease, provide any necessary support, emergency care, and transport the patient for further evaluation. In situations where access to care is delayed, remove the tick by using fine tweezers to grasp the tick by the head and pull it straight out of the skin. Once the tick is removed, cleanse the area with antiseptic and save the tick in a glass jar for identification. Do not handle the tick with your fingers. The patient should follow up with their healthcare provider as soon as possible. Injuries from marine animals. Colicentrates are responsible for more envenomations than any other marine animals. Examples of colicentrates: fire coral, Portuguese man-of-war, sea wasps, sea nettles, true jellyfish, sea anemones, true coral, and soft coral. The figures on the screen show examples of colicentrates. Jellyfish is A, Portuguese man-of-war is B, and a sea anemone is C. The stinging cells are called nemocytes. Signs and symptoms. Very painful reddish lesions in light-skinned individuals. Lesions extend in a line from the site of the sting. Headache, dizziness, muscle cramps, and fainting. To treat a sting from the tentacles of a jellyfish, a Portuguese man-of-war, or various anemones, corals, or hydras, remove the patient from the water. Remove the tentacle by scraping them off with the edge of a sharp-tipped object such as a credit card. Do not try to manipulate the remaining tentacles. This will only cause further discharge of the pneumocytes. On rare occasion, a patient may have a systematic allergic reaction. Treat the patient for anaphylactic shock. Give BLFs and provide immediate transport to the hospital. Toxins from the spines of urchins, stingrays, and certain spiny fish, such as lionfish, scorpionfish, or stonefish, are heat sensitive. The best treatment is to immobilize the affected area and soak in hot water for 30 minutes. The patient still needs to be transported. If you work in an area near the ocean, you should be familiar with marine life in your area. The emergency treatment of common coelurite envenomations consists of the following steps. Limit further discharge from the pneumocytes by avoiding fresh water, wet sand, showers, or a careless manipulation of the tentacles. Keep the patient calm and reduce motion of the affected extremity. Remove the remaining tentacles by scraping them off with the edge of a sharp-tipped object. Immersion in vinegar may also help alleviate the symptoms. Provide transport to the emergency department. Okay, class, let's go over some review questions. Review question 1. When a person is exposed to cold temperatures and strong winds for an extended period of time, he or she will lose heat mostly by A. Radiation, B. Convection, C. Conduction, or D. Evaporation. The correct answer is B. Convection. Occurs when heat is transferred to circulating air, as when cool air moves across the body surface. A person wearing lightweight clothing and standing outside in the cold, windy weather is losing heat to the environment mostly by convection. Radiation is the transfer of heat by radiant energy. B is the correct answer. C. Conduction is the direct transfer of heat by contact. D. Body moisture evaporates and cools the body. Review question 2. Shivering in the presence of hypothermia indicates that the A. Musculoskeletal system is damaged, B. Nerve endings are damaged, causing loss of muscle control, C. Body is trying to generate more heat through muscular activity, D. Thermoregulatory system has failed and the body temperature is falling. The correct answer is C. Shivering in the presence of hypothermia indicates that the body is trying to generate more heat through muscular activity. In early hypothermia, shivering is a voluntary attempt to produce heat. As hypothermia progresses, shivering becomes involuntary. Answer A. Hypothermia is not a physical injury. B. Hypothermia is not a physical injury. C is the correct answer. D. The thermoregulatory system has not failed. It is producing heat and keeping the body warm. Review question 3. All of the following are examples of passive rewarming techniques except A. Removing cold, wet clothing, B. Administering warm fluids by mouth, C. Turning up the heat inside the ambulance, D. Covering the patient with warm blankets. The correct answer is B. Passive rewarming involves allowing the patient's body temperature to rise gradually and naturally. Removing cold, wet clothing, turning up the heat in the ambulance, and covering the patient with warm blankets are examples of passive rewarming. Administering warm fluids by mouth or intravenously is an example of active rewarming. This should be avoided in the uncontrolled hospital pre-setting. All of the following are examples of passive rewarming techniques except Answer A is a passive rewarming technique. Answer B is the correct answer. Answer C and D are also examples of passive rewarming. Review question 4. A woman has frostbite in both feet after walking several miles in a frozen field. Her feet are white, hard, and cold to the touch. Treatment at the scene should include rubbing her feet gently with your own warm hands. B. Trying to restore circulation by helping her to walk around. C. Removing her wet clothes and rubbing her feet briskly with a warm wet cloth. D. Removing her wet clothes and covering her feet with dry, sterile dressings. The correct answer is D. When treating a patient with frostbite, you should remove any wet clothing and cover the injured area with dry, sterile dressings. Do not break any blisters, and do not apply heat to try to rewarm the area. Answer A. Do not rub or massage the frostbitten area. B. Do not allow the patient to stand or walk on frostbitten foot. C. Do not apply something warm or hot. D is the correct answer. Review question 5. A 30-year-old male who has been playing softball all day in a hot environment complains of weakness and nausea shortly after experiencing a syncopal episode. Appropriate treatment for this patient includes all of the following except A. Giving a salt-containing solution by mouth, moving him to a cooler environment at once, administering oxygen via non-rebreather mask, placing him in a supine position, elevating his legs. The correct answer is A. Treatment for heat exhaustion begins by moving the patient to a cooler environment, removing excess clothing, administering oxygen as needed, and place the patient supine. Elevating the patient's legs may improve blood flow to the brain and prevent another syncopal episode. If the patient is not nauseated, give a salt-containing solution by mouth. Give nothing by mouth if the patient is nauseated. Doing so increases the risk of vomiting and aspiration. A is the correct answer. B. This is an appropriate treatment for heat exhaustion. C and D are also appropriate treatments for heat exhaustion. Review question 6. You are assessing a 27-year-old woman with a heat-related emergency. Her skin is flushed, hot, and moist, and her level of consciousness is decreased. After moving her to a cool environment, managing her airway, and administering oxygen, you should A. Give her ice water to drink. B. Place her in the recovery position. C. Cover her with wet sheets and fan her. D. Take her temperature with an axillary probe. The correct answer is C. This patient is experiencing heat stroke. After moving her to a cooler area, managing her airway, and administering oxygen, the single most important treatment for her involves rapid cooling. Turn on the AC in the back of the ambulance, cover her with a wet sheet, and begin fanning her. Consider applying chemical ice packs to her groin and axilla. Follow local protocols. Untreated heat stroke almost always results in death due to brain damage. A. Give the patient nothing by mouth. B. Place the patient in the shock position. C is the correct answer. D. The core temperatures are most accurate. Review question 7. It is important to remove a drowning victim from the water before laryngeospasm relaxes because A. The patient will suffer less airway trauma. B. The risk of severe hypothermia is lessened. C. Less water will have entered the patient's lungs. D. You can ventilate the patient with a laryngeospasm. The correct answer is C. Even small amounts of salt or fresh water will irritate the larynx, causing it to spasm. This is the body's protective mechanism. If the EMT can safely remove the patient from the water before the laryngeospasm relaxes, the amount of water that enters the lungs will be minimized. It will also be easier to ventilate the patient. Answer A. A laryngeal spasm is the closing of vocal cords. This process will not cause trauma to the airway. Answer B. Submersion will produce hypothermia with or without the presence of laryngeal spasm. C is the correct answer. D. A laryngeal spasm is an upper airway obstruction and will not be able to ventilate until it relaxes. Review question 8. A 13-year-old girl is found floating face down in a swimming pool. Witnesses tell you that the girl had been practicing diving. After you and your partner safely enter the water, you should A. Turn her head to the side and give 5 back slaps. B. Turn her head to the side and begin rescue breathing. C. Rotate her entire body as a unit and carefully remove her from the pool. D. Rotate the entire upper half of her body as a unit supporting the head and neck. The correct answer is D. When caring for a patient who is in the water and has possibly been injured, rotate the upper half of the body as a unit, supporting the head and neck, until the patient is face up. Open the airway with a jaw thrust maneuver and begin artificial ventilation. Answer A. You must consider a spinal injury. B. Manual stabilization must occur when treating patients with suspected neck injuries. C. While in the water and placing the patient in the supine position, a controlled rotation of the upper body will automatically cause the proper rotation of the lower torso. The correct answer is D. Review question 9. Shortly after ascending rapidly to the surface of the water while holding his breath, a 29-year-old diver begins coughing up pink, frothy sputum and complains of dyspnea and chest pain. You should suspect and treat this patient for A. An air embolism, B. A pneumothorax, C. A pneumomodasm, D. Decompression sickness. The correct answer is A. Signs of an air embolism which present after a person rapidly ascends to the surface of the water while holding his or her breath include skin molting, pink froth at the mouth or nose, muscle or joint pain, dyspnea and or chest pain, dizziness, nausea or vomiting, visual impairment, paralysis or coma, and even cardiac arrest. A is the correct answer. B. A pneumothorax is a rupture or perforation of the pleural causing air to leak into the pleural sac. C. This is air found in the mediastinum between the lungs. D. This is a condition marked by joint pain, nausea, loss of motion, and breathing difficulties. Review question 10. 3 ambulances respond to a golf course where a group of 6 golfers were struck by lightning. 2 of the golfers are conscious and alert with superficial skin burns. Group 1. The next 2 golfers have minor fractures and appear confused. Group 2. The last 2 golfers are in cardiac arrest. Group 3. According to the reverse triage, which group of golfers should be treated first? A. Group 1. B. Group 2. C. Group 3. D. Groups 1 and 2. Group 3 should be tagged as deceased. The correct answer is C. The process of triaging multiple patients who were struck by lightning differs from standard triage. It is called reverse triage. If the patients are alive at the scene, survival is likely. Delayed cardiac arrest following a lightning strike is uncommon. If the patients are in cardiac arrest, there is a good chance that they can be resuscitated with early high-quality CPR and defibrillation. Therefore, Group 3 should be treated first. Answer A. Delayed cardiac arrest following a lightning strike is uncommon. This group should not deteriorate. Answer B. Delayed cardiac arrest following a lightning strike is uncommon, and this group should not deteriorate. The correct answer is C. Answer D. Group 3 has a good chance of surviving with quality CPR and defibrillation. Okay, class. This concludes the lecture on Chapter 32, Environmental Emergencies. If you have any questions or concerns, please contact your instructor, and I will see you in the next chapter.